Welcome, everyone, to this exciting webinar today. We are super excited to be with you. My name is Ryan Howells, Principal at Levitt Partners. This webinar is called Kill the Clipboard, What the CMS-Aligned Network Strategy Means for the Future of Interoperability. We are super excited to have you. We were overwhelmed with the amount of folks that wanted to participate in this webinar. So Anish, Dave, and I are super excited to be able to chat with you about this exciting movement towards more data exchange and more interoperability for the country. We will jump in now to what we're going to do today. First thing we wanted to talk about is this idea that just kind of set some ground rules here. We today, from an objective perspective, we want to talk about the announcement that was made last week in terms of a CMS-aligned network and how private sector initiatives are actually finding ways to be able to help implementers, especially early adopters, with adopting a lot of the commitments that were made last week. Anish is going to talk a little bit about public-private sector partnerships. We're going to talk about something called the Karen Alliance, if you're not familiar with it, that's been focused on consumer-directed exchange for many, many years now. And we're going to also talk about potential business opportunities this new modern API infrastructure could represent. As we are moving forward with the webinar, and I would say from an audience perspective, just remember that this is largely for CTOs and CIOs and others that are in the space, but certainly from a business perspective, we're going to highlight some of the business opportunities that are available as well. If you have questions for us, please use the Q&A feature. We will get to as many of them as we can. We can't promise that we will get to all of them, but we do promise we will answer all of those questions in a follow-up, because you will be receiving a copy of this webinar. You will also be receiving the slides and our answers to those questions in a follow-up email that will be coming next week. So with that, myself, Dave, and Anish are super excited to be with you today. A little background on myself. As we mentioned, the principal Levitt Partners. Levitt Partners is a healthcare consulting firm that is part of the HMA family that is focused on public and private sector ways in which we could advance good federal policy. And we do this thing where we form multi-sector collaboratives to try to solve really difficult issues within healthcare. We've done a lot of that in the public health space. We've done a lot of that in the quality measurement space, the quality data space as well. And we tried to take a lot of those ideas and put them into a paper that we wrote earlier this year in March, and it was called Kill the Clipboard. And so we wrote that with a group of multi-sector stakeholders to say, hey, new administration, here's a really set of ideas that have been around for quite some time, a few decades, in what you could do to actually make data exchange and interoperability better. We were super honored and pleased that they named one of the initiatives Kill the Clipboard. But we want to be super clear to this group that Levitt Partners is not running or organizing this initiative. This is 100% CMS run. Again, it was flattering that they named a little sector of this Kill the Clipboard, but I just want to make sure it's clear. And a lot of the ideas, by the way, were from the paper, but those ideas are not ours. They are the community's ideas. They are ideas we got from all of you. We put them in the paper, and now CMS has said, these are good ideas. We are also supportive of them. And now we, like you, are going to join this movement, as Amy calls it. It is a movement to figure out ways where we can kill the clipboard. But I just want to be super clear. This is a CMS initiative solely. Dave, let's go to you.
Yeah, it's good to meet. Well, good to be with everybody. Dave Lee, I'm also with Levitt Partners, and bring a little bit more of the public sector experience. I started my career on Capitol Hill and help with a number of the initiatives that we do as we interface with the federal government, and specifically Capitol Hill. I've been with Ryan since we started the Karen Alliance about 9 years ago, and I'll talk a little bit more about what we've learned about consumer-directed exchange. There's been a lot of commentary since the event last week around privacy, and I'll talk a little bit about what we anticipate moving forward from a data privacy perspective as well. So I'll turn it to Anish to introduce himself.
Thanks, Dave and Ryan. What a wonderful day, and what a great group that's joining us. I have also been in the public and the private sector, having been both Virginia's Secretary of Technology and President Obama's Chief Technology Officer. Spent a lot of my time thinking about the public-private partnership interface. We founded a firm called Care Journey, which ended up being one of the larger researchers of CMS data, and we merged with a firm called Arcadia, which is an active user of some of the interoperability standards we're going to be talking about today. So in many ways, I love seeing both sides of this, what it means in the public sector to call these ideas into action, and what it means in the private sector to execute and implement, and make sure that this all ultimately improves the quality of care for the American people.
All right. With that, we're going to move to our first section. Well, the agenda. Let me lay out what we're going to plan on doing. Anish is going to start on government, what really lessons learned. He is, as folks know, one of the primary folks that have been doing this for so long and have a ton of lessons learned to provide to us. Secondly, we're going to talk about the actual announcement itself, what it said, what it didn't say. There's a lot of somewhat misinformation out there, but we're going to try to really articulate the words that came from the announcement. We're going to talk, Dave's going to talk a little bit about the Caring Alliance and how we've actually advanced this for nearly the last decade. And then we're going to talk at the end about what does it specifically mean for you? If you're a healthcare technology company, if you're a payer, a provider, an ACO, a state Medicaid agency, what does this actually specifically mean for you? And then we'll talk about like the future. What could this look like in the future, and how could this really improve the consumer experience and really the email address for how you can get involved if you'd like to participate. So with that, I'll turn it over to Anish.
Thanks, Ryan. I thought I'd share a little bit of context setting for the announcement. It was not a rule. It was not a grant funding announcement. It was a call to action with a bunch of stakeholders who showed up on day one with a commitment and an opportunity for anyone else on today's webinar and throughout the country to raise their hands and participate. So I thought I'd start out with a little bit of history. What is that? What does it mean to have a call to action? And I refer to this as an all hands on deck approach, which is a policy lever that we used in the Obama administration. Now, for policy historians, my good friend Tom Khalil has a term for this. It's policy entrepreneurship. He was my mentor and guru in the Obama years, and he highlighted this notion that the bully pulpit of the White House is a particularly powerful convening function. And one of the areas that we worked on this was in a program called Startup America, where the president, asked Steve Case to lead an initiative with a bunch of stakeholders from the entrepreneurial community and from the kind of large corporations looking to buy products and services from startups. And it was a call to action to begin. But as the project unfolded, we uncovered a bunch of regulatory barriers, which we were able to address through rulemaking over time, and some structural issues, including how we regulate the underwriting process for entrepreneurs and startups, which led to the Bipartisan Jobs Act. And President Obama often said Washington operates within the 40-yard lines. This happens to be a topic, this all hands on deck for healthcare data sharing, that's absolutely historically been bipartisan. So I want to highlight a few particular attributes that make this a unique moment in time and what gives us confidence that this will be a successful endeavor. Number one, full alignment. The president, through the HHS agencies, including most importantly CMS and the National Coordinator for Health IT. We've seen this rodeo 3 times in the last 20 years. At the dawn of the original call to action for electronic health records, which President Bush made in the State of the Union in 2004. And I put a quote from the press release when they launched the formal executive order calling for the National Coordinator's Office for Health IT. Quote, when arriving at a physician's office, new patients do not have to enter their personal information, allergies, medications, or medical history since it is already available. Ryan, that's Kill the Clipboard before Kill the Clipboard, right? That's 2004, day one. President Obama, of course, famously put the HITECH Act into the Recovery Act, and that's a critical moment. But it was really the 2015 Precision Medicine Initiative where he personally led the call to action. And I will highlight in that announcement, he said consumers should have access to their own health data and to the applications and services that can safely and accurately analyze it so we can empower individuals and families to invest and manage their health. Very similar to what we heard this past week. I have a screenshot, not of the State of the Union like President Bush, but with Obama sitting with a patient advocate named Zoe, who regaled on stage the tragedy of having to get CD-ROMs of images of her husband's cancer from Dr. A to B hundreds of miles apart because there was no way to physically transmit the records. And you heard the exasperated voice in President Obama that we need everyone on board to help address this issue. Which brings us to last week's culmination event, the health tech ecosystem event at the White House, where President Trump himself said that the key breakthrough we've made is getting many of the biggest names to agree to industry-wide standards for electronic medical records. What I want to highlight in this all-hands-on-deck policy is that we're specifically talking about a consensus process to implement standards. So that's the second topic I want to highlight. So there's 5 things. We covered the first one. What is an all-hands-on-deck approach? The second topic is the primacy of industry consensus in standards processes. Now, this may sound like a little bit of a convoluted governance model, but the United States has been very firm. We do not have Moses tablets from Washington that dictate the way the industries, health, education, banking, or otherwise, must conform. We don't make up standards. We rely on industry consensus efforts. Now, a little personal history. In early Obama, we were not only investing in health records, we put $10 billion into smart grid. I happen to have one in my house. We went from a meter that would be read manually monthly, and it would lead to the bill we would pay for our utility bill. But the meter that was installed that was, quote, smart was generating information every 15 minutes. And the current structure, when it was initially designed, was that the only person that would get that data was the utility company. I would still get my monthly bill. So the question I asked, why can't we give a copy of that data feed to the consumer? So if they're overusing the energy that month, they could curtail their use and avoid bill shock if they felt like they, had more control if they had the information. We did not know what the government could do when it wanted to drive the industry towards standards, but the industry itself hadn't reached consensus. So in this second concept, Cass Sunstein, who ran the Office of Information and Regulatory Affairs, basically the regulator in charge of standards, process, and policy, and my colleague at the Trade Representative, since it has international trade implications, we penned a kind of a memo, an update that said, hey, we understand that there are certain areas of national importance, and health record sharing is, critical among them. Not just them, but also health records and energy, education, you name it. How do we think of a model of government engagement in standards activities when you've got a national imperative that isn't being met by private sector efforts alone? And the answer was, we can actively call to action. We can invest, we can convene, we can facilitate, we can do a lot more. So if you go back in time, what did the White House announce last week? Well, the White House is going to begin convening, not to start from scratch, but to build on the current standards that are in place. We'll get into some of that when Ryan goes into the detail. But that we obviously are going to have to do real-world implementation, testing, feedback, and iteration. So it looks a lot more like an active convening role. And we did this once before to great success, which was the direct messaging program. Just at the same time the Trump administration was announcing this health tech ecosystem, just a week or two earlier, they celebrated the results of the direct project. We hired a guy named Arian Malik, a brilliant engineer from the private sector, came into the government for a tour of duty. We led the committees, the working groups. We kept it open and collaborative. We had secure email people from Microsoft and Google. We had industry experts and healthcare standards bodies. And together we came up with a very simple, lightweight, low-cost protocol. So you could basically move email through email-like messages throughout the healthcare ecosystem. And at the bottom, Direct Trust, the governing body for this movement, demonstrated just hyper growth in the number of transactions that have run through the network, hitting records this year. So it's no longer a little kindling of an idea that we bore in Washington. It's now bearing fruit out into the real world. So that's the second point. We must recognize that the nature of this project is about getting us, the industry, to reach consensus on technical standards so that they can be adopted and used. Third point. I know many of you on this call were not among the initial 60 who were named as initial pledgers or signatories. And there was a lot of debate on social media. Who are they? Why were they picked? Why wasn't I picked? And shouldn't I have been in the room? And I want to highlight a critical success factor here is to get your mind out of who was there on day one and focus instead on the outcomes that we're looking to achieve, to give that individual a much easier process to check in and check out of a physician visit without having to repeat everything in the clipboard, or to be able to communicate with an AI-powered agent to interact, to understand and interpret the results of their health data. And also to think about ways that they could use all of this to work together to either reverse or prevent diabetes, or at least to slow its progression down. I want to highlight one of the pledges announced in the originally in the Trump administration version 1, and then kind of expanded upon in Biden, and that was the Veteran Interoperability Pledge, which had about 13 health systems willing to collaborate to better identify who a veteran is when they show up. You know, if you do the eligibility verification today, you know what insurance plan you're on, but there isn't the equivalent of an eligibility verification to understand, are you already a veteran, and might you already have a health account in the VA or benefits that are available to you that we can incorporate in the mix. And I'm proud of organizations like Tufts and Sanford and Marshfield Clinic and others who were early adopters, to the point where both Epic and Cerner, now Oracle, have made freely available software so that any of their health system customers can basically replicate the functionality. By the way, it was so the transaction volume got to be so big, it actually crashed the VA servers. So we might have to wait a minute until the VA gets a little bit of an upgrade on their infrastructure, because it can't handle the volumes coming from the health systems that wanted to be a part of it. But I highlight Multicare wasn't among the initial 13. But you can see that they've had dedicated staff helping veterans because they're in a community that's got a pretty high veteran population. And they've already, what is the number? 200+% improvement, 230% improvement in helping refer veterans to get benefits. So you can sort of see the outcomes are what matter, not whose names were on the first list and that worrying about whether you were or you were not part of it. Now we get to the fourth point. If we get to the fourth point, I want to highlight the perils of misalignment. All hands on deck efforts don't always work. And conversely, policies that lack an all hands on deck effort might be doomed to failure. And we saw two examples of this in the recent past. Back in 2014 or so, Congress passed a law called the Protecting Access to Medicare Act, PAMA. And in that act, it called for Medicare to adopt some form of prior authorization like service, where physicians, the ordering physician for advanced imaging, had to demonstrate that they checked evidence-based guidelines and had to write or attest to the fact that they had done that in order to get paid. Well, it's been a decade since this policy, which never went into effect. And CMS finally raised its hands in November of 2024 for the Performance Year 25 final rule and said, quote, "We have come to believe that the real-time claims-based reporting requirements prescribed by whatever section of the bill presents an insurmountable barrier for CMS to fully operationalize the AUC program. AKA, we cannot have nice things because IT doesn't work." Now, what's frustrating to me is that while CMS relied on the traditional EDI vendors, the transactional systems, to implement this policy, in the FHIR community, and I'm a volunteer like everybody in the Argonaut project, which has a lot of the major EHR vendors, we voluntarily worked on a technical approach using FHIR called CDS hooks. And you can see the results of Microsoft did a demo day on the technology standard. And you can see that it works exactly as expected. The CDS could be listening to see if the physician's ordering the advanced imaging studies, can present the evidence and workflow, and can push a button to say, are you currently adhering to that evidence or not, and give you a green light, red light, or not. And so this particular example is frustrating because while CMS turned off a project that was aiming to save taxpayers $700 million a year, over here in Fireland, we're waving our hands and saying, well, we have a thing, you can use it, but no one from CMS showed up. So that was sort of a sad day. Misalignment. Same exact problem in price transparency. Ryan and I have been working on a program called Project Clarity. You can barely squint to see a screenshot of Project Clarity, but in the price transparency rule, there was this idea of good faith estimates. How do we make sure that when a patient is about to get care, that they can request, as Congress intended, a basic estimate of what it is that's going to be done, and from their insurance company, given their deductible and co-insurance and other factors, what that means to me out of pocket. CMS in April of 2024 said basically, we're not capable of moving forward on rulemaking on good faith estimates because at the end of the day, it's not working. There's no technical standard. But over here in Project Clarity land, we were waving and saying, CMS, look at us. Here's an open standard that allows you to tackle some of the issues. The biggest issue being today we transact in individual line items like CPT codes, but you have to almost assemble them in bundles or mini episodes. And so with Project Clarity, with the help of Turquoise and HCCI and other stakeholders, we open sourced over 300 episode definitions or good faith estimates that you can download for free and use to basically set up the basics of what your good faith estimate and then advanced EOB should be. So if you don't have alignment, if there isn't an all hands on deck effort, and there isn't a commitment to standardize the approach, you get these fragments and misaligned, really negative outcomes, which leads to the final statement. It requires a table, a balanced table, where you've got data suppliers, in this case, EHR platforms, health systems, health plans. You got to get applications that will be demanders or users of this information with patient consent. These are the AI apps that you heard about, the Kill the Clipboard apps, the conversational AI, and the diabetes prevention or disease progression apps. And you got to bring policy at the table. And we've seen this movie before in the Apple Health entree to into the health data ecosystem. And to briefly summarize it, so I can pass the baton to Ryan on what we're actually doing in this policy, Apple Health showed up in 2017-ish, as CNBC noted, quote, quietly working to turn your iPhone into the one-stop shop for medical information. At the time, Apple was working with the Karen Alliance and the Argonaut Project to understand the technical standards that they ultimately implemented into Apple Health records. By the way, Penn Medicine was one of the first to implement this, one of the first 13 that went live early 2018. And they asked questions of the patients. What was it like? And it was, I love having my health information in one place. I don't want to have an app for each provider, AKA hyperportalitis, the very thing that the health tech ecosystem announcement said it wants to get rid of. So the Apple Health story is a powerful story. And you can see it in the context of the work we've done in Karen, where then Administrator Seema Varma issues a speech at HIMSS within weeks. We had a working group. We had technical standards, consensus activities. CMS implemented Blue Button 2.0 a year or so later, and bringing the rest of the industry with early adopters through regulation. So we see an opportunity to put all the pieces together so the health tech ecosystem will be not only successful, but wildly successful in putting to bed the challenges we faced in the last decade, getting the new digital assets that we've brought to market with all the EHR investments and the like into the hands of consumers in the applications they trust. And with that, Ryan, tell us what actually happened substantively on that day.
Awesome. As always. Thank you, Anish. Appreciate it. And thanks for all the questions too that are coming in. So let's talk about kind of this announcement and kind of what led up to it. So as we mentioned, we wrote this Kill the Clipboard paper. You can see it if you Google Kill the Clipboard or levittpartners.com, kill-the-clipboard. You can read some of these ideas. There were certainly ideas that were in the CMS RFI that came out in May-June timeframe, and then also what the administration announced last week. But there are other good ideas that are out there, just so you know. And we tried to collect, certainly not all of them, but a lot of them that are there. As Anish mentioned, this is a once in a generation opportunity for us to get all of this stuff right. So we really want to try to make sure that this happens. But what we said in our paper is there's a lot of good things you can do for consumers. There's a lot of good things you could do for B2B exchange. There's a lot of things we could do to actually improve TEFCA and how this actually operates. And certainly digital identity is core to making all of that actually happen. And then CMS came out in early June and said, you know what, there's actually a set of things that we as CMS are going to do to be able to improve this overall ecosystem. One is we're going to build this dynamic interoperable national provider directory, essentially a digital address book that's going to have provider directory information in it, but it's also going to have FHIR API endpoint information in it too. It means that I can find you digitally on the internet. Right now, we don't have that in healthcare. We don't know how to actually find each other. So this is going to give us an opportunity to do that. And I'm certain that, our hope, I should say, is really that CMS and ONC can work together so we can have this single ability to be able to access this information going forward for both TEFCA and the work that CMS is doing. Secondly, they said, we're going to build this identity verification process with Medicare.gov to streamline credentials. So this is digital identity. Digital identity is the ability for you to prove that you are who you say you are across systems. There is a NIST guideline from the Department of Commerce, and that NIST guideline is called Individual Access Level 2 and Authenticator Access Level 2, IL2 and AL2. That's the shorthand for folks like ID.me and Clear and login.gov that offers these digital identity credentials so that you can use them as a single sign-on across multiple different systems. That's really exciting because then that starts to unlock the data because much better than we do today, because we have usernames and passwords, which unfortunately are hacked all the time. But if I am using an identity proof credential, I can then be able to use it across multiple different systems, which is really exciting. It's personal, it's privacy preserving, and it's more secure than anything we have in healthcare today. And it's all consent based. Third thing is they said we're going to expand the use of the CMS Blue Button Initiative. I think folks know what that is, but that is the claims data model that's on FHIR that we actually developed in the Karen Alliance, as Anish just pointed out. We're going to also transition the data at the point of care pilot to general availability, which is exciting for providers who want access to the Medicare claims data. That's an exciting thing. And then they talked about expanding CMS's participation in trusted data exchange. These are things that CMS did, which is really exciting to say we're also at the table. We're also a player in this space, and we think we can help with infrastructure. Then the July 30th announcement happened. There were 60 plus organizations mentioned, as Anish talked about. There were 11 different health systems and providers, 21 different data networks, 4 payers, etc. I want to double down on Anish's point. Don't worry if you weren't there. Please, this is, we're going to talk about this here in a second, and Amy mentioned, this is a movement, not a mandate. This is all about direction in terms of where people are going to go in the future. If you want to be part of this movement, we want you to join this movement. And as Anish mentioned, action speaks much louder than words. So in the next few months, and hopefully over the next year, the folks that are really going to move on this stuff and are going to commit as an organization that they want to move faster, it's going to really be a private sector competition in terms of how this actually moves, right? How do we get people to get moving in a manner that is consistent with these principles? And then we'll see, hey, let's start promoting this. We will do our best. Like, how can we say, look, here are great opportunities, just like Anish mentioned, of people who have actually done this. That's what's really going to be exciting. So as we mentioned at the outset, this is a volunteer framework. That's what the CMS actually said in their announcement itself. They did not mention anything about building a massive database or a network or tracking your healthcare information. Unfortunately, there was a bad press announcement about the fact that the government is tracking your healthcare. They didn't mention, from our perspective, any of that in this announcement. It's actually just the opposite. It's actually empowering us as patients with access to our own data. How do we facilitate that infrastructure? That's what's exciting. So this is words from their press release: collaboration, not compliance; movement, not a mandate; call to action, not a regulation. They were very clear in their announcement that this is not a regulation or a mandate. It is a movement. It is a direction that the industry can go in. It's about building reusable technology. Today, what we have is a lot of proprietary stuff and a lot of closed proprietary standards. And things that are really healthcare specific. We're moving to a modern API-based infrastructure that can be reused for multiple different use cases to solve multiple different business problems. Public-private sector collaboration, as we mentioned, and really person-centered engagement. Digital identity has been going to be core to doing all of that. It's going to solve a lot of those problems that we have, again, on a volunteer basis, voluntarily to do that. As I mentioned, there's the email again. You're going to see it again at the end of the presentation. If you want to pledge your organization's support for these topics and these areas, email CMS. They are the ones leading this effort. They are the ones that are collecting these emails. You will be part of this public process that's going to occur over the next few months. That's the really benefit and opportunity. But there was other news that was made, and it happened. Unfortunately, it happened at the earlier meeting that happened during the day, so it wasn't public. But the National Coordinator for Health IT, Tom Keene, talked in that earlier discussion that was there. He then gave a quote to Politico, I think it was last week, on August 4th, about what are the national coordinators' priorities in order for them to be able to support what CMS is doing. And he mentioned two priorities that CMS is looking to do. One is certification of APIs to improve interoperability, and the second was enforcing information blocking. And those two ideas, those concepts, exactly, we can have nice things, right, Anish? Like these two concepts are absolutely game-changing. Why? Because now if they start to think about how they change the cert program to certify APIs rather than certifying the functionality inside the EHR, it unleashes more innovation inside the EHR and outside the EHR than we have ever seen in healthcare, ever. And so that is really exciting. We'll have to see how that transpires, but that comment that Tom made, Dr. Keene made, I should say, on this idea of certifying APIs certainly will really unleash the ability for health systems to use this data the way that they need to for non-EHR purposes, and also promises to be able to say, how do we unleash innovation for all the healthcare technology companies that are out there as well? So we'll have to see where that goes. So what did the announcement talk about? Folks have read it by now, but these are some highlights related to it. There was a lot about patient access, and there was a lot about patient consent preferences, audit log transparency, how as a patient know where their data is being sent. Down in the left-hand corner there, you'll see some standards, open standards that are there, all linkable, all going to be available to you next week when you get a copy of this presentation. So you can see that a lot of work has already been done on a lot of these different areas. We are not complete by any means. This is not, we don't have all the answers, private sector, really, or public sector. That's why it requires the convening that Anish talked about. How do we actually build this together? They talked about conversational AI assistance as well, which is going to be really interesting. Obviously, we wanted to make sure that that information is safe and reliable and trustworthy and non-biased. And how do we figure out a way where these are done in a very safe way for consumers? And then there was a section on diabetes and obesity prevention and management of how this could actually operate. And there were people that committed to doing that. Then there was a question about EHRs and payers and others. Digital identity was a really core element of all of this. We will talk about this later, but if you want to be in this game, you do need to have a digital identity ecosystem infrastructure that supports it. You need to have a FHIR API infrastructure that supports it as well. If you have those two things, you're going to be able to connect to this new network-like capabilities, which is going to be wonderful. Insurance and authorization. They talked about digital insurance card. Dave's going to talk about the standard we developed in the Karen Alliance to make this happen. And other topics as well around what those commitments are. I'm going quickly, but yes.
No, but let's marinate. If you go back for a minute, Ryan, just because I want to marinate in the goodness of this, just to make sure that people have gotten the perspective. We've had these two regulations that have been islands to themselves. The CMS Interoperability Rules, we're now referring to them as 0057, which provides mandates that payers for government programs share provider access API with doctors, and no obligation for doctors to reciprocate back. One-sided. Then ONC rules say that you have to have the ability to share data with a trusted partner you choose, opt in, your choice, but no mandate to share. So part of what this is doing is it's motivating both sides to essentially have a bit of a reciprocity here. Providers get access to payer data. It didn't say only for government-sponsored plans, so that may imply all lines of business. And it offers payers the chance to say, hey, for certain data elements, I think they talk about the, within 60 days of the in a paid encounter, that the payer gets access to the data. And for this debate we've been having in what is treatment, I live in the ACO world, so ACOs that we work with, if they wanted to pull data for quality measurement, like MSSP ACO reporting, that was deemed more operations than treatment. And so CMS says, no, that's now that operations use case, that's going to be part of the CMS-aligned network. So Ryan, I'm going to double down on this as being different than the current regulations. It's expanding access to more data once you've made it through that security funnel. So the audience should realize if you're a health plan, not being a part of this is a huge mistake, because this is your only open path to access information. And for providers who are just looking for a common way to talk to everybody in the same format, as opposed to custom bespoke one-off initiatives, this is your easy button. So there's a huge win. Forget the good of the patient. There's a huge win for both parties. So I just wanted to highlight this particular page includes things that are not currently on the docket in either of the two regulations.
And I want to be clear too, you're not saying forget the good of the patient exclusively. You're just saying
in addition to,
it's good for patients, it's good for providers, it's good for payers, right? It's good for health IT company. This is a goodness all around scenario, right?
There are very few initiatives where everybody benefits from participating. Very, very few things in life. There's usually a winner and a loser. This feels like we all get to have a little bit more of what we dreamed of when all of this digitization happened in a bipartisan way for the last 20 years. Hence the enthusiasm in the voice.
We can all have nice things, right? There you go. That's where it is. Okay, awesome. More about this. They also mentioned, I'll just mention a couple of these, must support terminology compliance as well. Down in the bottom left-hand corner, if you have not heard about it, it's called the PICI framework, piciframework.org, PIQI. It's an open standard. It's going to be an open standard as of September with an HL7 to improve the data quality between systems. It's an ability to measure that data quality that we're working with the clinical architecture team on, that we're super excited about as well. That could be an asset that could be used by the private sector to help support the CMS commitments that are there. And then record location services. We've been talking about for a while in TEFCA. One of the values of TEFCA is that you can use record location services to find the information, where the information sits in the network. And we need that because the network itself is such that we need to make sure that we're making efficient and effective queries to those different endpoints to pull the data back for the specific purposes that you need. And certainly TEFCA can be able to provide that. With that, I'm going to transfer to David. Dave, and he's going to talk a lot about the Care and Alliance work that we've done over the last few years.
Thanks, Ryan. And it's really good timing. A lot of the questions in the Q&A are calling out some of the privacy dynamics and some of the privacy questions that folks have coming out of the back of the announcement. So what is the Care and Alliance? How was it formed, and what does it do? The Care and Alliance was formed, as Ryan noted, about 10 years ago by folks from the Obama and Bush administrations, including Anish and Governor Mike Leavitt, David Brailer, and David Blumenthal, to say, look, we advanced a number of different priorities during the Bush and Obama administrations, but we didn't get everywhere we wanted to be. And some of this is going to require, again, significant private sector activity to advance access to information. And specifically within the context of the Care and Alliance, how can we help consumers get access to their information so that they can use it where they want it, how they want it, for the purposes that they want it? We're not going to tell consumer A that they have to do X with their data and consumer B that they have to do Y with their data. We want to empower consumers, patients, caregivers to make the decisions that they want for their care and have the data that they need to do that. And over the last decade, we've had over 100 participant organizations, and at any given time, about 75 or 80 or so that are participating. And with that, there have been a number of different activities. And on the next slide, we can talk a little bit about one of the core areas that's the Karen Code of Conduct. So as has been noted in the questions and it has been noted in some of the online articles since the conversation last week, consumer-facing applications in any of the three categories where announcements were made last week are not subject to HIPAA, right? Consumer-facing applications are facilitating an individual right of access request, another part of HIPAA, right? Individuals have the right, the absolute right to get a copy of their data. The end, period. They can choose the format they want, and they could choose the partner that they want to help pull that information, including consumer-facing applications. And a number of the consumer-facing applications that have participated in Karen and some of those that have not came together several years ago and said, look, we want to hold ourselves to a standard. The government may not amend HIPAA, the government may not expand HIPAA, that may not be appropriate. We're not going to have a conversation about that, but we want to have a standard so that we can say we are doing the right thing when it comes to transparency to a consumer, when it comes to getting consent from a consumer, that we can say we are following the most up-to-date industry best practices for data security, and that we are making this data available for the consumer when they want to move it to a different app, or they want to share it back with their provider, or they want to give it to their health insurer. And so the code outlines a number of ways that consumer-facing applications, should be transparent about, obtain consent for, the use of data and how they're going to manage that data. So what does the code do? There's basically three different levels that we have established through the code. And the foundational level is that application developers attest to the principles of the Karen Code of Conduct. This is a self-attestation. They look at all of the sections of the Code of Conduct. They look at their terms and conditions and their privacy policies and say, all right, we agree to align our terms and conditions and our privacy policies with this. We're going to make a public declaration that we are attesting to the Code of Conduct. What does this do? Across a number of states and at federal law with the FTC, that attestation, that public attestation, means that if they ever do not follow the Code of Conduct or deviate in their terms and conditions or privacy policies from the Code of Conduct, the FTC or a state can come in and make an enforcement action against them and say, look, you made a public declaration that you were going to do something and you're not. Phase two, additional disclosures. App developers, through a number of different mechanisms, make additional disclosures to their users about how they're going to use data. And again, through terms and conditions, through privacy policies, through educational materials that they give. Over the last couple of years, we've been excited to see phase three really come to fruition, and that's a validation layer. Karen does not itself validate or do any certification, but we now have Direct Trust, formerly ENAC, or ENAC started it, doing attestation here and saying, look, we're going to come in and verify that you are actually following in the appropriate ways the Code of Conduct as outlined. What does this mean for users, right? They can have trust in the Karen or in apps that have attested to the Karen Code of Conduct because they are doing specific things. We'd go through an annual update every year to make sure that we are aligned with new announcements like the one today, or state laws as they develop, or new federal laws if they come through. So what does this look like? On the next slide, we've got a few examples of folks who have attested the Karen Code of Conduct and are listed on myhealthapplication.com. And again, would encourage folks to go look at myhealthapplication.com. It's a type of app gallery that includes a number of consumer-facing applications that have said, we are willing to attest to and put our name on the Karen Code of Conduct and be held publicly responsible if we deviate in any specific way. So on the right side of these columns, you'll see the attestation. Next to Be Well there, you'll see an additional note because they have been through a third-party certification to say that they are doing this. So for folks that are wondering, what are the consumer-facing applications that may have signed one of the pledges? What are the ones that have attested to the Code of Conduct? Go there. It's a great resource. If you want to aggregate your health information, use one of these apps. They're competing on privacy. They're competing on security. They're trying to keep your data safe based on your individual preferences. Do you want to share your information with a life sciences organization that may be working on a therapy that's specific to your chronic disease? They may be able to help and facilitate and donate that data. If you want to keep your information only on your device and never share it with anybody else, you'll be able to find an app that can do that too. So I'd encourage everybody to go there. I'm going to go quickly on these next couple of slides. One really important area where we've seen adoption of the code of conduct is through federal regulatory action and from federal data holders, right? So we have the interoperability and patient access rule and the interoperability and prior authorization rule that Anish and Ryan have already talked about. In both of those rules, CMS recommends that for payers and for data holders and for consumer-facing applications that they leverage the code of conduct to say who are the best apps that are making these attestations and are willing to compete on privacy and security. For the VA Lighthouse program, right? If you want to access the Lighthouse API, you have to attest to the Karen Code of Conduct. That is a precursor to their onboarding process. And again, it's because we want to make sure that the consumer-facing applications that aren't covered by HIPAA are doing their best for transparency, consent, data security. We've talked about TEFCA in the chat a bit, or in the Q&A. TEFCA, some of the SOPs have already also pointed to the code of conduct. So last, and then I'm going to turn it back to Ryan and Anish to talk through some of the implications. The last slide of our section really talks about what are some of the resources that Karen has developed in addition to the code of conduct to facilitate this, and would focus folks on the Karen IG for Blue Button and the Karen IG for Digital Insurance Card. Ryan has talked about a bit. Some of the areas where these will help data holders and others facilitate some of the exchange in the commitments that were made. There's others here that are really important. And as we look at the broader Fire Accelerator community, Anish talked about the Argonaut project. Folks have been in the chat or the Q&A talking about DaVinci. This is really an example of what Anish talked about at the top. We have to align standards. And going through an SDO process with HL7 and with these Fire Accelerators leads us to a place where we get to a really good outcome in a number of areas. So with that, Ryan, I'm going to turn it back to you as we continue on to the next section.
All right, so we're going to pick it up and see if we can hammer it home. But what does this mean for you? So certainly for consumers, the headwind is pharmacy costs. Folks can't afford their drugs. There is an open standard called Real-Time Pharmacy Benefit Check that we developed in the Karen Alliance that has been actually proven to reduce out-of-pocket costs by 50 to 75%. What's really interesting and exciting about that is that 7 states require it now and 2 states require an API. We could implement that very quickly without regulation. And a lot of the PBMs are actually working with us now to actually install that. That's exciting. 2, there is an opportunity now for a patient to have a true longitudinal health record. The great news is there are companies that are in the Karen Alliance that have already shown that this is the case. And so this is actually happening right now, that patients can have a portable health record that they can provide to their physician and others that they want. We think online registration is the way to kill the clipboard. Can you prove that you are who you say you are? Can you aggregate your own data? And can you share your insurance information? There's a lot of inefficiencies that go away in the healthcare system if you can do those 3 things online with your physician before you step into their office. Data sharing, we're going to see that patients now has visibility into where their data is going and how their data is being used. Super important.
Just pause on that, Ryan. Is that available today in any of the current networks?
It is not, to my understanding, Anish. So
that's a big win.
It's a big win.
We get to have access to the transaction logs, which is something that I think is something consumer advocates have been asking for a while, and now this gives us a bit more comfort. So there was a lot of commentary in the Q&A. How do I know who's doing what? There was some reference to the particle health Epic situation. A lot of that is happening behind your back, for lack of a better word. It's invisible to you as a patient who's been interacting and querying for your records. So thank you. I didn't mean to stop you there, but I just want to pause on the really, kind of big new item here.
I think it's a fabulous pause. The other thing I would say on the last one to pause on is that the Smart Health Card standard is brand new. Literally in the last few weeks, it's been validated. You can see it in the HL7 Smart Health Card, Smart Health links. The interesting thing about that is that it actually solves the provenance problem. So it actually cryptographically signs the data from the source system to the relying system. So if you're sending your data from Johns Hopkins to Mayo Clinic, Mayo Clinic will know that that data came from Johns Hopkins, even if it went through a patient or an HIE or somewhere else. Cool thing for patients, cool thing for B2B transactions too, because I'll know where the data was coming from, right, Anish?
Ryan, what does this mean for NCQA HEDIS audits?
Wow, that could solve that problem too, right? We've
I
got
don't know. We're talking about cost efficiencies and administrative transactions, people. Win, 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 and win.
win-win all around. Super exciting. Very true. What about providers and ACOs? Anish, what are you excited about here?
Well, look, we can go through the same list, but in addition to just sort of in many cases for providers, the revenue cycle is an area of friction, right? It's a high cost. Estimates are what, 25% waste in the system for administrative purposes, prior auth, insurance verification, confirming what your out-of-pocket costs are, all of that headache. Once we get to the place where the digital insurance card comes in, I literally, I've got my brace because I had a fracture on my wrist. I don't want to name the health system. It's a beautiful system, academic medical center, amazing clinical quality. I've gotten 6 phone calls. What was your insurance card again? Is it XXP? Those were dropped. And what were I'm like, you billed it like 15 times. Oh, but that was a different department. That was the outpatient center. I'm the hospital. I'm like, don't you talk to each other? No, we don't. So like this sort of hilarious like reality of our system is going to be, reduce that burden. One version of truth, one digital insurance card, replicable, audited, shareable. I also think for the health systems that run ACOs, this goes live March 31, 2026. And if we're lucky, some of the networks will get going even before because this is, Ryan, to your point, competition. So you choose the network you trust, and maybe you're going to pick the network that's going to go live the soonest. Why? Every MSSP ACO by March 31, 26 has to report quality for every single patient they treat. So if that's 11 million Medicare beneficiaries, that's probably 40 to 50 million Americans need longitudinal records on 3 or 4 quality measures, blood pressure control, depression screening, and the like, diabetes management. How are they going to collect all of that information on 50 million people with, nurse auditors or whatever they do manually? It's just not realistic. So you might actually get some serious tailwind for the ACOs eager to have something that's not a wasted effort, which is the current, I think the current plan. So this is a win-win on revenue cycle. It's a win-win on ACO and quality improvement activities, and then all the patient engagement activities. It may not be unrealistic to imagine on discharge. I hand you your discharge instructions, but maybe I also authorize you for a week or two to have access to a conversational AI that can help you explain it, understand it, and escalate to the care management team if something's not right. Because we know it is that 30-day period post-discharge where you're at the highest risk of readmission and other downstream ill effects. So quality, administrative burden reduction, and consumer engagement.
Awesome. So on the health plan side, certainly risk adjustment, chart chasing costs. A major health plan I knew recently told me I think they're paying $30 a chart to actually go get some of this stuff. Like there's opportunities here where if the patient consents, that's the key piece, right? If the patient consents, there's an ability for that to occur. But even beyond that, if there's an opportunity for the payer and the provider to work together to use the APIs themselves, there's opportunities there for them to exchange data too, using a common structured data format. E-prior authorization. We don't have our friend Anisha Taylor on the phone, but she would tell you she's been in production for 3+ years. Literally now 93% of her prior authorizations are literally resolved in real time. So all the DaVinci APIs that are being required by CMS on January 1st.
With the payer that works with her on it.
Regents, and
Thank you.
Our friends.
Shout out to our friends at Cambia, and I think Premier is next in line, and Humana is there too. So the family is expanding.
Family's expanding. Providence as well. They're doing this. 93% of the time, it relieves that burden from the provider, and so and it allows for the payer to be able to eliminate the calls and faxes they're getting today, and it's beneficial to the patient because of the fact they get an answer back in real time. So let's solve 93% of the problem. That sounds great. Quality measurement reporting, great progress on quality measurement reporting. You've seen the RFIs come out from the administration. But this idea of using Fire APIs and CQL rather than the QRDA infrastructure that we have today, or at least transitioning more to API-based, is certainly a priority. And how do we work together to make that happen? State Medicaid agencies, lots of opportunities here too. Reusable architecture, right? I'm going to be at MESC next week speaking 3 times, and there's opportunities where we can say, how do we figure out a way to do modular-based certification that CMS has been focused on for quite some time? That modular-based certification comes through the use of these APIs at scale. Healthcare technology vendors, this is your moment, right? Like we go back to the comments that were made by Dr. Keene earlier last week about certifying APIs. Well, if that's the case, payers and providers and others and patients can actually use your technologies now to be on the network. We believe very strongly that if this, of all of this kind of comes together in a way that allows for this innovation to happen, that everyone is going to be a network. Patients, right? Providers, payers, go ahead.
Ryan, let me just put a finer point on what you just said, the certification of the APIs. ONC publishes a table of all the, I think it's now 300 certified G10 fire servers. I believe a third of those certified products, EHRs, rely upon fill in the blank, health IT company, cloud vendor, take your pick. So we're already seeing in the certification of the existing G10 servers, by adding this relied upon, that while the server being certified is the EHR vendors, they're heavily reliant on someone else. So this just takes it to that next level. So this is market expanding and acknowledging what's really on the ground happening anyway.
Yes.
So let's dream for the future, Ryan. How are we dreaming in the future?
All right, let's dream for the future. I know we've got only 4 minutes left. What could this look like in the future? Okay. Again, this is all just an idea of like, how do we bring all of these pieces together? We have legacy data there at the bottom, right? That all of these different disparate legacy data systems that you have today, we think that in the future, folks are going to have this cloud-based consolidated enterprise data store. They're going to have this cloud-based data store that says, I'm going to manage, if I'm a payer, I'm going to manage that data. If I'm a provider, I'm managing this data. If I'm an aggregator, I'm managing this data. But they have a cloud-based way to do that. And it's going to have all of this API data as part of it, which is really exciting. And then on the left, they're going to have a digital identity layer. We think that's absolutely critical. For those who don't know and aren't following it, TEFCA actually requires that everyone on TEFCA have an IL2, AL2 credential. So that is super important as well. And CMS has now said that's important to them. So that is really, really important to have that digital identity. So we know who you say you are, we know what organization or individual you represent, and we know what data you need. And then on the right side, we now have Inferno, which is the ONC's tool for making sure that the APIs are conformant with the regs. We also now have Picky that makes sure the data itself is of high enough quality to be able to send to another party. And then if you layer that on with the API framework where everyone has that API gateway, you have a situation where folks have digital identity and API gateway, you become part of the network. Whether you're a patient, whether you're a provider, whether you're a payer, whether you're an HIE, whether you're an HIT company, you will all be part of this network. You can use up in the left-hand side record location services on TEFCA to find out which endpoints you need to hit in order to access the information. And on the right-hand side, you're going to be able to use the public utility of CMS building the payer, provider, and API endpoint directory for your usage. And that's the way we can have nice things, right, Anish? We can put people can work together, ONC, CMS, the private sector. We can have nice things.
Now let's acknowledge this is you and me speculating.
Of course, yes.
And so obviously, as CMS leads this effort and gets consensus among those who are committing. By the way, I want to be careful. Don't just say, "Hey, I believe in you, sign up." I think if you are committing to implement, that is, if you're a health system willing to be on a network, if you're a health plan willing to have your data on the network, if you are a network itself looking to connect these dots and to meet the requirements, if you're a consumer-facing app, you got to commit to being like what you are, not just this hey, good luck. Let me throw thoughts from the outside. Be in the arena. Maybe that vision comes to life, Ryan. David, your point about the Karen Alliance, my final conclusion to you is we may go beyond HIPAA, frankly, in some of the provisions we have in the Code of Conduct. So you may actually get more protections. Like you have to disclose, you have to state whether you intend to comment on secondary use rights. So this issue is an area where, by collaborating, Ryan, we're going to make a lot of progress. And because of the president's all hands on deck call, we're just going to get there a lot faster. That's, I think, the headline.
So we went through the last two slides quickly. You're going to get all the slides. You're going to get all the recording information. You're going to get the appendices as well with all of the links associated too. We'll answer all of your questions in an appendage to this and into a document. Thank you for all of you joining. If you're interested in joining the CMS initiative and you are supportive of what they're doing, use that email that we showed multiple times in the document. Send that email to them. If you're interested in engaging in private sector efforts to doing that, feel free to reach out as well to us. But certainly this is an exciting time. No better time, right, Nish, than to be into healthcare tech than where we are right now. But we appreciate everybody's time today. Have a fabulous rest of your day, and thanks for participating.